Hello, everybody. Good morning, good evening in different parts of the world. Thank you for joining us in this really exciting webinar by CyberSight. I am joined today with my friend and colleague, Dr. Shalinder Sabherwal from Delhi. I'm Dr. Anand Vinekar from Narayana, Nethralaya, Bangalore. Both of us are from India. A quick disclaimer, although this webinar is on artificial intelligence screening models in the real world, both of us are just clinical clinician ophthalmologists. And much of the work that we might talk about may actually be going above our heads, and we may not even be able to answer some of your technical questions because AI is such a black hole, and sometimes we don't even know how it's doing what it's doing. However, our intention is to present work that has a very specific India and a lower middle income country context. And therefore, there's a lot of great work going on in AI, both in diabetic retinopathy, glaucoma, and retinopathy of prematurity across the world. And we may not be able to do justice on all those models in our talks. A quick roundup of how we are going to conduct this. I'm going to be the first speaker, and I'm going to speak about AI models in retinopathy of prematurity for about 15 to 20 minutes, followed by Dr. Sabherwal, who's going to be talking about the anterior segment, AI models for glaucoma and diabetic retinopathy. Right, so I'm going to be talking about AI models, integrating it into the real world for retinopathy of prematurity. Firstly, AI is such a big buzzword. We have AI running on our phones, maybe in even traffic signals. So why AI in ROP? Is it just a cool thing to do? Well, it's certainly cool, but a little more than that. There are more reasons for getting AI into ROP. Firstly, the numbers are absolutely staggering. Look at where India is a decade later. From 3.5 million, we're still over 3 million preterm babies born annually. And look at the other countries as well. So what's happening here is there are tons of babies who are being born premature, who survive, and of course, who need to be screened. And then there are fewer and fewer ROP specialists to do it, which basically means that it might come down to imaging. And imaging, therefore, naturally lends itself to AI models. Firstly, why is there such a big ROP problem? This is one of the editorials we wrote. Other than the fact that blindness is a big deal if the screening programs are not in place, the fact that today there is a much better survival of preterm babies, even in rural areas, has added to the burden. As I mentioned, it's really all about imaging and images which are lending itself to the AI model. Let's look at the new international classification of ROP, which came just about under 3 years back. And in the preamble itself of that classification, it talks about one of the reasons why the new classification was required. And look what it says, the innovations in ophthalmic imaging. Right from understanding the notch, which is a disease going into the posterior part of the macula, to the fact that plus disease and pre-plus disease, a term that came in 2005, is so variable that we must agree to disagree. And to further complicate our lives, we've started addressing things like mild pre-plus, severe plus, and so on. Well, at least the ICROP 3 classification decided that we must now expect and accept the fact that today plus disease is a spectrum. From no plus at all, there could be very obvious plus. And to help us understand the vascularity and the vascular abnormalities, we look at this digital subtraction or the segmentation from green, which is no tortuosity at all, to red, which is completely dilated and tortuous. A quick recap on some of the stages of ROP. This is not a talk that will address that in detail, but just from the context of AI. So when there's just a simple line between the vascular and avascular retina at stage 1, stage 2 is a slightly thicker line which has volume, which is raised. Stage 3, on the other hand, is extraretinal fibrovascular proliferation and neovascularization. And you can see in the stage 3, there's in the picture here, at least, there is plus disease, which is dilatation and tortuosity. You also have the notch, you have other abnormalities like popcorn, and there are combinations thereof. The other scary part of ROP, which we are seeing more and more often now in middle-income countries, especially in India, is aggressive ROP. The older term being aggressive posterior ROP, and posterior word being dropped because we now know that abnormalities can extend all the way anteriorly. The second reason why imaging is becoming so much more commonplace is the fact that we now have affordable and portable cameras. Let's take the Indian RedCam, which is invented and produced by the Forest Health in India, which is called the Neo. It is more portable, lightweight, and has a better resolution. In this publication, we had compared the RedCam family of cameras with the Neo. There are also even more affordable versions where you just simply tag on your cellular phone or onto devices that can host and hold a 20 diopter or even a 28 diopter. Great for photo documentation, still not completely integrated into a telemedicine platform. The point being is that we're going to have tons and tons of images as camera costs go south. In the format of CyberSight, we are going to have a few polling questions just to make this more interactive. We're going to have it's up there for you to read. I'm going to allow you 30 seconds, after which the CyberSight team will put out the results of your poll. So with regards to plus disease, is it easy to differentiate? It is easy to differentiate arterial and venous tortuosity. Pre-plus and plus are distinct from each other. Pre-plus disease is sufficient to make a call for treatment, and the P-score provides some objectivity in understanding the gradient. Okay, so 24% of it's almost equally divided. So I'm guessing then, and that's exactly the purpose of this poll, was to tell you that we now have some objectivity in place. With the fact that we were struggling with plus disease across the world, from the US to the West, Europe, all of them said that experts hardly agree on what is plus disease. And this publication came out only last month from a few of us in the ICROP group, where we hope that some amount of objectivity will come in. From P1, which is no plus at all, to P9, which is, as you can see, very obvious plus. And we hope that in some way we would be able to communicate between each other by saying today it was P3, last week it was P2, and so on. And this is some printout that you could probably put out in your clinics and use it. Now, these are all important with an AI model, and that's why, and the rest, regression and reactivation, is for us to get the complete understanding of this ROP process. So regression, as we can understand, is the disease coming down on its own. And well, unfortunately, after anti-VEGF, there are different patterns of regression. Reactivation, on the other hand, is when the disease comes back. And the disease can come back in several different forms, either in the form of abnormal plus disease, or again, pre-plus and mild pre-plus, or the reappearance of the ridge and the stage 3. Quickly break for the second poll question related to the last 3 slides. And the question is really about regression and reactivation. So the patterns are similar after laser or anti-VEGF. So yes or no, incomplete regression is more common after laser than anti-VEGF. The timing of recurrence after anti-VEGF depends on the drug used, and reactivation is always characterized with reappearance of plus and ridge tissue. Okay, so the point, again, it's almost equally divided, but the answer here is that the timing of the recurrence depends on the drug. Okay, and all of the others are false, and which is something that we'll look forward to going into as the talk happens, and perhaps a bit of it in the Q&A as well. Now, the journey of artificial intelligence, at least in our program, the KidRaw program, which is in its 18th year, stems from the fact that we started screening in more and more SNCUs, and as more cameras, both the RedCam and the Neo, started getting used, we started having tons of images, close to 100,000 images every month. And we realized that as this program was scaling up into different states and countries, we are going to be dealing with a ton of images, which we must know how to decode. So about a decade back, when we were dealing with some low quality images certain times in ROP, we figured that maybe there are algorithms to better understand or pull out more clinically useful information. So we always had this problem where we couldn't see the vessels reaching the end, or some amount of capillary non-perfusion, which we saw in aggressive ROP, was not picked up. Sometimes the resolution was bad and quantification was not possible. So this is work which we did with a Bangalore-based company called I2I Telesolutions. They used here it is, contrast limited adaptive histogram equalization techniques, popularly called in the engineering terms as CLAHE. I'm just going to cut the chase to say that we use 3 filters. Color enhancement, which allowed us to see capillary non-perfusion, a gray enhance, which allowed us to see where the ridge was either raised or where the vessels ended, and a really cool measure called the vesselness measure. And this was by trial and error. As you can see, sometimes it gave too much of noise, like in image 2 or 4, and sometimes it gave too little noise, and the details of the clinical picture was being missed. Similarly, with the color enhanced, the vesselness measure was interesting because we were able to see smaller capillaries that extended beyond where the clinical picture showed it would. Let me illustrate this with an example. Now, this is a really severe case of posterior zone 1 aggressive ROP, in those days called aggressive posterior ROP. The blue line is somewhere where we might think the vessels end. But if you run our algorithms of CE protocol and more importantly, the vesselness protocol, you can actually see that the vessels extend much beyond. And these are probably capillaries. They were always there in the original image, just being missed out because of the detail. And in this paper, we showed that close to 15 to 20% of these images that were classified as zone 1 or even zone half or posterior zone 1 were reclassified as zone 2 and vice versa as well, because we were able to see finer details extending more anteriorly. So that's really the advantage of doing that. Now comes a segmentation and quantification. This was work done with an engineering college in Bangalore, where we looked at tortuosities in multiple trees, and we looked at it in a range. Again, our idea was to look at the subtype of aggressive posterior ROP in those days, and where we looked at not only the tortuosity, but also how abnormal dilatations happened both in the posterior pole and in zone 2, because aggressive posterior ROP was in the original classification said to occur in zone 1 and zone 2 posterior. What's important here is that we were able to quantify it, and because of that, perhaps it would be a great tool to assess outcome for treatment. Plus disease we spoke about. What about detection of zones? So this is another bit of work we did with two independent engineering institutions in Bangalore and in southern India, where we looked at plus disease and we tried to use the same form of structural adaptive segmentation. And here, since pre-plus by definition in those days was 2 quadrants and more than 2 quadrants was plus disease, we looked at histograms that would delineate the two and see whether it could be extrapolated to the entire image. This was work done by the Pune group. They've done wonderful work as well, and I've chosen one of their publications which helped detect the zones, even when the macula was not fully developed. Now, let's understand that by definition of zone, when we said 2 disc diameters from the center of the macula, and if the macula and fovea itself is not well developed, how do you make that distinction? And that's where they used automatic detection of all zones. And I think that's been a very good tool that can be used clinically. In terms of 3-dimensional reconstruction, this is work that we worked with, again, engineering colleges in Bangalore and outside. Let's look at this case of a retinal detachment, which is stage 4A, potentially 4B. And the way the retina is ballooned, we reconstructed that image into 3-dimension to understand how it was lifted. And remember, if these images were being taken by healthcare workers, they would be helped by understanding whether this was stage 2, which was flatter, or stage 3, which is by definition extra-retinal fibrovascular proliferation. Using deep learning methods, and this is work we did with the Indian Institute of Technology, Madras, where they started using poor quality images to enhance them, process them, work on their ridge, using ridge detection methods, then filtering them, looking at them under different filters, and then working on their predictive models, firstly focusing on the region of interest, and then comparing it with the ground truth, and then extrapolating it to images that were either which had poor quality and are the ones that were marked with the ground truth itself. Basically, all of that, what it did was in images that were very obvious stage 2 or with ridge, we extrapolated the information we learned from there, and we were able to pick it up in images that did not have that good quality, but were actually having the disease itself. This was another deep learning approach which we did with the Indian Institute of Technology, Hyderabad. Again, these images were layered, and here they adopted a different format where first we labeled it based on the ground truth, and then there was some pseudo labeling based on the algorithm itself, and then we fed both the true and the pseudo labeling back into the algorithm to see whether the learning improved. And as you can see, the accuracy was very good at 99%. and a great range of sensitivity and specificity as well. This then moved on to taking images that were misclassified, the idea being that even if there was a poor quality image, can we extract clinically useful information? And this is the publication where we compared it with other similar models of deep learning using the deep neural network. And as you can see, it had great sensitivity and specificity. In automatic detection, I have 3 or 4 examples. This was a single person funded PhD where her algorithm basically learned a stage 2 and was able to differentiate it from a stage 3. And as you can see, the accuracies were in the early 90s, and they are only improving as we integrate them into the real world. This is work done by Pete Campbell's group in association with groups in India, Nepal, and Mongolia. Again, the idea was to see whether AI can help a population to reduce the number of unnecessary screening visits by flagging them at a different score, and can they identify high-risk infants who need to be more closely monitored, who might potentially go into treatment requiring ROP. And they showed that this is possible across ethnicities as well. This is our own work where we used AI across 3 public institutions, PGI, All India Institute, and us, where basically we said each of those models works in their own ecosystem. Can we have the leader of that system and the people whom they train, are they on sync with the way they classify the ground truth? And that was the idea on whether AI can be used for training. And training across the board under different circumstances. And as you can see, there was the green polygons are the where we agreed, and the red is in the dipstick method where we disagreed. And this was between experts and team members. And we can then identify team members who are early technicians learning how to train, learning to image and improve their skill. Our most recent publication is the one where we are using now different cameras. And here we realized that by using plus only, there was a good accuracy. And by using ridge detection only, there was decent accuracy. But when we combined the two, we could actually integrate it into the real world, into either the algorithm telling us that this baby needs treatment, needs follow-up, or is completely normal. So this was referenced by the ground truth of the technicians in the outfield, and again validated by ROP specialists sitting in the main center. Our work was to, of course, focus on the true negative and positives and reduce the false positive and the false negatives. And here, as you can see on this slide, it worked across the RedCam Shuttle, RedCam 3, and the Forest Neo. I'm going to quickly allow this user interface to play. This is how the live video works. Of course, this is a cruder version. This is part of an ongoing grant with Government of India's BIRAC department. And we have some milestones to meet by next year. And we hope that the algorithm will be ready. And as you can see, it's going to be device agnostic. So here what we're doing manually, quite manually, is uploading the right eye and the left eye and submitting it for prediction. And as you can see shortly, in a few seconds, and we only think that the speed would improve as it gets integrated into the real world. And as you can see, the report shows up in a few seconds. And this is exactly live. This video is not being edited. This is how long it would take in the current scenario. And you can see that it would generate a report where the heat map would show you where the disease is, and it will tell you whether this baby needs to be referred or treated or is completely normal. So you can see that this is early stage 3 in zone 2 posterior with plus disease or at least pre-plus disease. It's not telling you all of that as of now, but it's saying that this baby needs referral. And this is the sensitivity and specificity across the RedCam and the Neo. And as you can see that this is really good. It's almost 100% when you compare it with the experts. It drops a bit when you compare it with your technicians who are screening in the outreach. I'm going to end with the fact that we can add to fundus images the several more modalities. And I bring to your attention angiography, which is coming of age now because of anti-VEGF. And this innocuous looking retina, when you do the angiogram, shows you so much of persistent avascular retina. And well, also diless angiography or OCT angiography could lend itself to artificial intelligence. As of now, the devices are not specific to pediatric, and therefore much more work needs to be done. And of course, OCT, which has also come up in the ICROP3. We have been doing some work in OCT of infants, where we've shown that some of those layers may appear late or not appear at all, and they can code whether these babies will have poorer or normal vision. And I'm going to end with some exciting fact that we are now almost able to detect are able to predict whether our babies will develop ROP as they undergo screening by taking their tears during the first or second screening, examining their biomarkers, and then as these biomarkers increase or decrease and their ratios between each of them, we are able to predict whether these babies will eventually develop ROP or even need treatment. Some of our publications that address this, this is currently not into the AI algorithm, but it very much can lend itself into it, because we are also looking at systemic risk factors. So an image along with a risk factor, along with a tear biomarker, could be the way where we can predict these babies on developing ROP or not. In the first paper, we looked at angiogenic factors. In our second publication, we looked at the interplay of inflammatory markers. And in our third publication, we looked at the role of vitamin D in VEGF modulation. To summarize, advances in affordable imaging has really changed the way we are diagnosing, screening, treating, and following up these babies for ROP. The fact that there are so many babies to be screened, and AI and machine learning is going to be here to stay. And as real world integration happens, I think we are going to be seeing in the next few years a paradigm shift in the way we are going to utilize AI. I'm going to end with this final polling question. All of these answers are right. None of these are wrong. So the idea is for me to understand where do you think the maximum focus will be, and that will help us further fine-tune our own AI models. So a last dig at this before I hand over the podium to Dr. Sabherwal.
Yeah, so I think my talk is more on the AI integrated community screening model for diabetic retinopathy and glaucoma. And it's basically impact. So it's not going to be as technical, because as fortunately, most of the algorithms have been developed and have been working well. There have been published studies showing the accuracy, sensitivity of these detection for diabetic retinopathy and glaucoma, especially the referable part of it. So I would not go into the technical part. I would rather go into how we are using it, and then how it can be actually make an impact in the community. So before I jump into the topic, I would have to define the context of community in our sort of setting. And just before that, I would like to just roll out this poll, just to know what sort of percentages are we seeing that, especially in India, because we've been working in Indian context. What do you think is the sort of people with diabetes who do not know their status? And the second question is about those who know their status. How many would have never got their eyes screened? And this is all published data. And up to sort of what percentage of glaucoma might be undetected in India? Okay. So I think for the first one, this is basically to highlight the need. And I'll come to this a bit later, maybe so let me say the percentage people in a national sort of rapid assessment of avoidable blindness, which was done between 2015 and 2019, we found between 30 to 40% people actually did not know about their diabetes status. And almost 90% had never got their eyes tested, even among those who knew that they were diabetics. And there are some studies which have shown that up to 90% of glaucoma in India might be undetected. So again, before going into the topic, I just like to share our community context. So we work at Dr. Shroff Charity Eye Hospital, which is a community care organization working in a pyramidal model. And we work at community level by doing door-to-door screenings and referring people with the need for eye care or vision to the next level at vision centers. which are the primary eye care centers. And this is where most of the sort of interventions are here in terms of the integration of AI. And here we have a vision technician or an optometrist who's well trained to do a comprehensive eye examination, uh, basically facilitated with the equipment required. And wherever required, they make the referral to the next level, which would be a surgical center, might be about 50 to 70 kilometers away from the vision centers, where all basics for cataract surgery work and basic subspecialty work, including management of diabetic retinopathy and glaucoma, would be taken care of. And we have a tertiary eye care center in Delhi, which, like any tertiary eye care center, would do all the subspecialty education, research, and training. So why go into this AI integrated model for community care? In our own context, actually, we did a rapid assessment of avoidable blindness, which is a survey which is quite standardized in terms of finding out need for or prevalence of blindness and its causes in a defined catchment. And we did this in around the biggest secondary level care center that we have, Pradesh, which is the most populous state in India. And the catchment was about 2 million people. And we included the diabetic retinopathy module there. And what we found was not very different, in fact, even worse than what was the national averages. 50% people did not know that they were aware of diabetes, and they were detected during that survey. 85% had never got their eye tested, even when they knew they were diabetics. And among women, this percentage was almost 90%. Glaucoma, as I already said, can be pretty undetected in India. And both these conditions, unfortunately, are not amenable to population level screening. So what happens is we have to use every opportunity available for opportunistic screening for these conditions. And that's where the community context comes in. And I think before I proceed, I would say that we are still learning and we are quite new in this intervention. It's been just a year, and we have consolidated our findings for last 6 months. And out of 100 primary eye care centers, it's right now we are at less than about 20% of those vision centers which are covered, but the interventions are at vision center level. Why vision center? Because we have a technician there. It's a referral point from the community, and it's closer to where people are. And it doesn't have an ophthalmologist. So what we have found is the training on this, and we are using fundus on phone, and the training is pretty easy. What we have found in our experience, we can easily train a technician in a day or two. And then it's only about refining the technique. And this training includes the training on the platform, as well as actually capturing good quality pictures. Is it easier than training a technician on 90D or the retina checkup? Definitely it is. But more than the easy part, it also standardized the training, especially at a peripheral level where there's a lot of attrition and regular change of human resources. So we found this very standardized and possible to train. Coming to the images, if you have an ideal condition, I'll come to that too. You get good pictures. The picture on the left shows the hemorrhages and cotton wool spots. May or may not be diabetes, but there's definitely not normal fundus picture. Picture on the right shows a disc which can be labeled as glaucomatous. But despite not having ideal pictures, it is able to show us enough to actually note down the signs which are available on the photo, even if it is not very clear. As per the reports, you do get sort of automated reports. And here there's always a word of caution. It's not diagnosis, it's screening, and it is indicator. And it can actually highlight where you're seeing the lesions for the technician. For glaucoma, again, it is indicative. It can actually basically point out the disc where it is seeing how it is seeing the disc and how it is evaluating. It is supposed to see the cup disc ratio and also the nerve fiber layer in different sort of quadrants. Once you get the report, you can actually proceed for referral. Another sort of thing that we have noticed is sometimes the images are not ideal. You can still bypass the sort of the quality check there, and it will give you a report saying that although you have bypassed the quality check, So you have to be cautious, but still it would tell you whether it is a referable case or not, which sometimes is pretty useful depending on the conditions of pupil that we find at the vision center. This is all non-mydriatic, so you do not have to dilate patients at the vision centers, which many of us actually avoid doing at primary level. As per the data availability, it can show you what vision center is doing what, where stations are. You can actually filter down data for each vision center to go into the depth of the data. With the new sort of dashboards being developed, it is supposed to be becoming more visual, and it can give you more data in terms of what exactly you have asked for. How many were the people actually referred for diabetic retinopathy, for glaucoma, AMD. So it is getting more granular. This is sort of our experience. And as I said, we have just consolidated in the last 5-6 months. The numbers of patients screened have been increasing. And so has been the number of patients screened for detected with the possible diabetic retinopathy, glaucoma, and AMD. As per our data, as of now, what we are finding is out of the detection rate for diabetic retinopathy is about 12% of people, and these are people above 35 years of age who have been screened, and glaucoma up to 7%, and for AMD around 3%. Coming to true positives, so when you actually filter them down to actually see what happens at the hospital, for the condition itself, we are finding a sensitivity of around 66%, they're matching. Not sensitivity exactly, but it's actually the positive prediction sort of rate that is there. If I actually look at only the sort of whether they were referable or not, that prediction rate goes actually up to around 80%. That means a patient might be referred for diabetic retinopathy, may not be diabetic retinopathy, but would definitely has a lesion for which that patient should have anyway attended the hospital. So whenever we roll out a program in sort of a public health perspective, we have to have some indicators for monitoring the program. And the first thing that we try to see is what percentage of patients are being actually screened out of the all attending the vision centers above age 35 or more. But this percentage, looking this in isolation, doesn't work in real world scenario. You have to facilitate people depending on the crowd at the vision center. You have to match it with the number of the sort of the OPD that the technician is seen daily, and then maybe facilitate them with more human resources, a junior person who can actually do the screening, or a second technician if required. Why some of them are not screened is because some of them have come for cataract surgery follow-up. They generally try to avoid screening in a 1-week scenario. Some of them had feeling that cataract grade 1 should also not be done, which we are trying to improve. Charging problem if there's a electricity break for a long period. And sometimes only single vision technician available. These are the factors which come out from the real world for sort of limiting the utilization. Then comes the monitoring of quality part of it. And fortunately or unfortunately, right now for them, there's no benchmark because it will totally depend on the type of people or patients who are coming to you in a real world sort of situation and with different sizes of pupil and sort of cataract grades of cataract. So we try to compare that with for each and every vision center, how many were ungradable. For in our scenario, we feel they should not be very different. How many actually ended up attending the referral which has been made is a basic quality indicator for any public health program. That means how many were actually connected to care. And that is where the percentages are still wavering. And I'll come to that, how we can address that. And then it comes to true positive, which can be an indication of the level of pictures being taken or the training which has been given. Another thing which the media's sort of Remedio platform helps you with is what percentage of patients actually you had to bypass the quality to get the report. And this could be due to multiple reasons. It could just be because of pupil size and the quality is still not there, but there are enough indication for a referable case. It could be because of early cataract, but it could also be because of training. And looking at these variation around the vision centers, we are in sort of planning a second way of training where we are only going to basically focus on the quality of images being taken by each technician. And some of the centers now are actually thinking of, should we go on and dilate these patients where we are actually bypassing quality instead of just pushing them forward. And that's something which has to be tested still. the sort of the major goal for us right now is increasing compliance to basically referral. And one of the ways we are thinking of is we have started putting these pictures on the teleophthalmology platform that we use, and maybe the clinician talking to the patient would motivate them more to come, because there's no other sort of facilitation given to that patient to come to the hospital, which might be about, as I said, 50, 70 kilometers away from the vision center. We are there's some undergoing research, basically more on the operation side. One is that what we are looking at is basically a multicentric research project to look at the efficacy of these tools at the vision center. And when I say efficacy, so apart from true positive, how many actually ended up coming in a real world? And so that is basically the output of the whole intervention. And the second thing that we found interesting was that could we use this non-mydriatic camera after dilating the pupil to make sure that they screen the fundus or the retina before cataract surgery, so that you're not dependent on an ophthalmologist to actually book a case for cataract surgery, and the cataract surgical patient can actually proceed from vision center to the hospital, with much more surety of actually being fit for cataract surgery. Whenever we talk about AI in real world, we have to be very careful about certain sort of things which can be a roadblock. One is about data confidentiality. How we should not be uh, sharing any sort of confidential information of the patient, even on a platform which is given by the company or which is not sort of your own secure. Consent has to be taken from the patient if you're taking images. And at the end of the day, you have to know that still it is a screening tool. So no diagnosis should be basically offered on the basis of the screening. So at the end, I'd like to thank all the supporters who have helped us acquiring these cameras and rolling out this program. And we hope to cover our all hundreds vision centers soon, and hopefully learn more from the ongoing research. Thank you.
So the first question is is AI-based ROP screening covered with health insurance? Not yet. In fact, AI is still not part of mainstream ROP diagnosis or even screening. So the question of getting it covered by insurance is probably going to be the next step. Which leads to another question on the medical legal aspects. But first, the second question is, Shalinder, to you, what are the medical legal aspects in AI-based diabetic retinopathy screening?
Yeah, I think there's sort of no clear-cut guidelines right now. What I would say that what I have mentioned in the last sort of slides is that we have to make sure that, one, this is not a diagnostic tool still. It is a screening tool. Consent for taking a photograph is a must. And you have to make sure the data remains secure. And because healthcare data is actually the top-notch priority for in the data protection law of India. And you have to make sure it remains on your own platform, which are secure and not shared with any confidential information. Maybe I would stop there, and there might be more. This is what I'm aware of.
Great, thank you. And just to add to that, India has a new DPDP law, and as far as imaging is concerned in ROP, for example, as we use it as patient information material, we have to sometimes preserve, and there are time periods for which the law states how long you need to keep these reports. But technically, an ROP image should be kept till the child turns into an adult. In fact, till the age of 21. Because it's 18 years plus 3, and that's what some of the older laws state, and we're still waiting for clarification on the rules. The next question is, what is the accuracy of the diabetic retinopathy and glaucoma screening with AI? Are there any misdiagnosed reports?
Yeah, I mean, thanks for the question. Actually, yeah, as per the published reports, yes, I think the diabetic retinopathy and glaucoma, whatever is published, shows more than 95% sensitivity, and touching up to 99% in STDR cases and referable cases. So that is what is available in literature. As for us, as I said, still the research is ongoing, so I don't have my published data right now to share. But in our cases, like I said, we are finding somewhere between 60 to 70% patients actually being as a who were referred actually needing that referral for that condition. But if I say for all the conditions together, it reaches up to 80% or so, which is not, which is quite reasonable in terms of a public health intervention.
Great, thank you. The next question is addressed to me. It says basically, it refers to the slide in which I showed the vesselness measure, which says that I showed a ridge in zone 1, and then the segmentation algorithm showing that the capillaries were beyond zone 1 and it actually reached zone 2. Did I have a ground truth for these images for the model to learn, and did I confirm these findings with an algorithm for clearer images using indirect ophthalmoscopy? Okay, so great question. This work actually was published in 2012, 2013, even before AI was a thing. We were doing mostly machine learning and we were doing segmentation and better understanding poor quality images. However, at that time, the ground truth that we used was a clinical indirect ophthalmoscopy, and we also, in certain cases, did a fluorescein angiography on the RETCAM 3. So we were able to see where the actual vessels were. The image, on the other hand, was poor quality for several reasons, germane to the ROP problem. In aggressive ROP, we know there's a rigid pupil often, there's tunica vasculosa lentis, and there's media haze, all of which precludes great images taken of the posterior pole, and that's when AI algorithms might work. I just hope that answered the question. Okay, the next question is to you, Shailendra. Is FDA clearance required for AI applications to be used? If yes, what are the FDA approved AI applications available for DR? Yeah, I think AI, definitely I can say for ROP, yet there is work in progress. There are some models that have been applied for, and I think if it has to become mainstream, it will require more of that certification. This is a generic question, I think, for both of us, perhaps. What is the cost of screening per person? I think it refers to you because you had spoken about the public health model.
Yeah, I think in our context, we have still not calculated that, but there are some studies which show not the costing, but it shows cost effectiveness of the screening. But I think that is where the what the operations research that we're doing right now would actually lead us to. It's not about screening one person, but actually screening and then connecting a true positive case to care. That will complete the cycle. And hopefully down the line, we'll have those results. But right now, it's very difficult to say in our context. As per the theoretical cost effectiveness as published in some Western studies, it shows it's cost effective in terms of the detection rate and what it comes out of it.
Right. And I think a follow-up question on your model is the next question, which says, what are the other healthcare delivery use cases in using AI for DR and glaucoma apart from the vision center screening?
I think that's an excellent question. And I think I should have included that because I'm talking only on my context where we have a very vertical sort of ophthalmology program. But a true sort of intervention should be how we can integrate these cameras in the physician sort of clinics, in the basically the non-communicable diseases clinics or the hospital where the physicians should be able to use that instead of waiting for these people to come to an eye care center when they don't have a complaint. So I think it has to be within a clinic because going door to door doesn't make sense right now, looking at the prevalences and the cost of the camera. But I would say that we have to integrate this with the general health setups, and then only it will be even more cost effective as compared to putting them in a vertical vision center or a primary eye care center scenario.
Right. And just to follow up that with a question from me to you, in terms of to make it really successful, it'll have to work with the public health delivery system. And what are your thoughts on how to integrate it with that? Because that's a separate challenge itself.
Absolutely. Absolutely. I think it makes it pretty easy now. We were struggling when there was no AI integrated into that, because even if you put a camera in an NCD, non-clinical communicable disease clinic, where there's no ophthalmologist to comment on the picture, we would always lose the patient. This AI makes it pretty easy. It can be done by any technician who's trained well. And the image itself, the AI report would guide you about the referable condition. And that is all we require at a screening level. So I think it is very useful to have the AI, especially where the ophthalmologist cannot be connected directly. And it's a real world scenario that is mostly the case at a primary level, whether it is a primary healthcare level or even at primary eye care level. So I think with India scenario, the primary healthcare centers, the sub centers, I think it has a great sort of usage potential for that.
Right. And I think we've kind of partly answered that question. The next one, what is the future of AI screening in DR and glaucoma in India specifically? And you've just said that. To take that, what you said a few minutes ago, it's not just about finding the true positive, but to actually integrating it for treatment. Now, how does one go about creating that ecosystem? AI is great in, like you showed, in the as peripheral rural centers, we can pick up patients who need treatment. But what I meant in my first question was how to integrate it in the public delivery system on getting that patient into the closest center where this treatment is available. It could be the community health center, it could be district headquarters, of course, it could be a tertiary care center in this closest city. How do you, and of course, this is a question more to your public health knowledge than the AI itself, but I thought it will complete the ecosystem. What do you think about that?
Yeah, again, thanks for the question. There are no easy answers there. This is where we struggle always. But I think there are two or three things that I can think of straight away. Is one, how do you train the technician to counsel using the images? Because now you have something in your hand to show the patient. Earlier, we didn't have that. So how do you use that for behavioral change? I think that is something which the technology platforms can also work on because they're already coming out with these reports. How do you make those effective communications? And second, I think now with teleophthalmology being quite standard in most of the networks, and how do you connect them directly with a clinician on the basis of positive reports, and can clinician counsel them better in terms of, and may or may not require a follow-up. So some of the referable cases would have very clear picture. We know it's a early stage diabetic retinopathy, doesn't require anything to be done right now. So may or may not even need that referral to the hospital. So I think that is something can be integrated to decrease both the patient load and increasing the sort of connecting to care sort of network.
Right. And I think you brought out a very important point of using the mobile phone, geo-tagging them, making sure that they are connected to the closest healthcare worker, and of course, integrating it into the public delivery system. Okay, let's move to the next question. I presume this is a generic question for both of us, or maybe it's me and I don't have the answer, so maybe you can help me. What are the current models for the use of AI in detection of astigmatism early in children that could give accurate measurements? I'm not aware of any such model. Are you?
Not really. I'm not really aware.
Right. So I'm not sure how that might work in terms of just image. So this would be an example of what I said, where we are using a metadata of the patient's systemic conditions. Similarly, if it's not just an image, obviously astigmatism is a numerical value as much as it probably is a a K value or something that we're getting out of the cornea. Both of these will have to be integrated into an AI model. It's not just an image. So I think we're looking at models beyond imaging, and I don't think we've come of age. At least we both are not sure of anything that's worked in the outreach. The next question is to you. What level of training do technicians have or need? Are they usually from the healthcare background, or is there no specific trend? Also, which fundus cameras are being used, and what is your opinion is the greatest obstacle of increasing compliance to referrals after screening? I know there are three questions, but they were all put into one. So training of technicians, which fundus cameras, and the greatest obstacle to increasing compliance.
So I think I've already started the third one we already discussed. Compliance is always an issue in any public health sort of intervention. And there are certain positives in this in terms of actual availability of image and possibility to put those images on teleophthal and then directly talking to the clinician. Coming to the other sort of question, which was about the need for the technician to be qualified. For frankly, we have tried with both. At the vision center, we have the luxury of having a vision technician. So we have used them who are actually trained technicians for 2 years and all that. But in a previous program, we have actually trained some community health workers who have sort of no background in ophthalmology or optometry. And it is just about taking a good image and how to train them to take a good image. And that's all they have to do with the AI already coming in. So I think that is not a very big obstacle in terms of requiring a technical person to take these images. That is sort of our limited experience. And again, for with the limited experience that we have just used Remedio as of now with the AI. We've used many handheld cameras, but with the AI integrated, we've just used Remedio fundus on phone. So I have only experience with that, and that has worked well as of now for us.
Right. I'd like to add a little bit about the same questions with its relevance to ROP. In our Kidrop model, we've actually devised a training methodology for training anyone who can be a imager. We used to call them technicians, but today we know we can train optometrists, nurses, paramedical healthcare workers with any educational background. And there is a 20-point program on how you can train them from anywhere between 2 to 6 weeks and accredit them. And such technicians, imagers for ROP, are being trained by our institute, and they go in different parts of India and the world. And as far as cameras go, in an ROP, we are unfortunately limited with the RedCam family and with the Neo family and the others that are integrated with the mobile phone. But as more and more cameras would come up, and we are hopeful that in the next 1 or 2 years, there are at least 3 or 4 cameras that I've seen in its beta version that it's going to come out, and we hope that will also our AI algorithms will be camera agnostic. And as far as the increasing compliance for referral, I mean, he mentioned that it's a problem in adults. It's an even bigger problem in ROP. But as he very rightly it's very rightly said, images can be used for patient education. And when you show the mother or the father or the family the image with the ROP, and you show them that there's avascularity and there's a ridge, and then they are convinced, and then they become part of the decision process. And then when you call them back, they do come. Next question, what are the sensitivity and specificity measures of AI models assessed with regard to ROP? Right, and I showed you in the journey that we had, our initial sensitivity was in the late 80s and the early 90s, and in our most recent, the AI Meteos is actually showing, well, and our initial training models actually showed 100% concurrence with the ROP specialist with the ground truth. Well, at least we can say in the late 90s is where we have reached in sensitivity. And for ROP, we are really putting in our money for the sensitivity, because we don't want to miss any true positive, because a baby that needs treatment must be picked up. Okay, next question. Considering AI screening models are trained on a specific population, can you comment on its applicability in other geographical locations? Specifically, do you think ROP screening algorithm developed in India would need to be adapted for the use in North America? And that's a great question, and I think some of it has been answered by the work that I projected with Pete Campbell. It's an American devised algorithm that was tested in Nepal, India, and Mongolia, and they show that across ethnicities, something that was developed for the Caucasian population is working well in other ethnicities as well. And I think the reverse will be true. The ones that we've developed in India will need to be validated and tested in Western ethnicities as well. But the quick answer is yes, it would work, and already some work has gone proving that. Shalinder, this one's for you. Was human-based DR and glaucoma screening occurring in vision centers already before you introduced AI? Or did the availability of AI to facilitate the introduction of the screening services for the first time?
Again, an excellent question. And we were not doing this earlier, only because we had done a small sort of pilot where patients, it was with everything in place, still we are struggling with compliance, and we're trying to see how we can improve that to beyond 30%. Earlier, what used to happen was we were dependent on somebody reporting on those images, and we were not leaving that to the technician. And to get a clinician on sort of tele suddenly within 20 minutes or 30 minutes to see those images and report was almost an impossible task in a very operational hospital. And so we never rolled that out as a program just because of that, because it was almost impossible to contact that patient later. And we found in that pilot, it was not working to contact them later. And so AI has definitely enabled or encouraged us at least to do that now, and hopefully scale it up in future.
The one question is actually asked to you and me, so I'll go first. Could you please share the training, validation, and testing data set numbers? Are these models approved by regulatory bodies, and have these models been compared with approved models internationally? Okay, so the training and validation data, as some of the slide shows, ours goes from anywhere between 35,000 to 100,000 images. Are these models approved by regulatory bodies? Not yet for ROP, but as I showed you, our last work is being done with Government of India's BIRAC, so we hope that that itself would be some sort of a validation. Have these models been compared with approved models internationally? Not yet. There's been a Western model tested in Indian ethnicities, and now we are going to hopefully test it in the West. Shailendra, to you, answer those questions with respect to DR.
Yeah, I think for DR, it has received a CE mark approval, Meteos AI. I am not so sure about glaucoma. So I think, but the studies that have been done have published and they've shown good results. But regulation, I think I'll have to check whether they have that for glaucoma right now. But the DR, definitely for referable DR, they have received the regulatory sort of thing from the EU.
Okay. Can AI detect ridge elevation using fundus photography images? Yes, the answer is yes. And all our algorithms have done exactly that. Question for both doctors: is the data set being used to train each AI based on the local population only? How many images have been needed to train the AI to this level? You can go first, Shannon.
Sorry, I don't have the specific numbers. And we can get back to this question, asking the going into the research. Yeah.
Here, I think our publications will carry the numbers. Obviously, the more we put in for the training set, the better the validation set is. And I just shared my answer in the previous question, so I won't repeat the numbers again. There is a question not related to AI, but to vitreous hemorrhage. Maybe we'll take that offline. I know you're able to share this. For the lack of time, we have probably a minute left. Is AI applicable, feasible for low and middle income countries? Yes, definitely. And as he would show how he showed it in the rural outreach for ROP, that's exactly where we think is got the buck for its money, because imagine the number of babies who need to be screened, a lack of expertise, and that's where AI can fit in. Are these AI applications to be, are they used outside India? How do you ensure that the data set used in the training AI is not skewed based on race and ethnicity? Well, I think he's answered that in terms of the algorithms for DR being used across the world. In India also, I told you the same. There are systems that have been used on different ethnicities, but yes, there would be a cross-ethnicity validation required as new softwares are developed. Do AI softwares mentioned require an active internet? Short answer, no. In your case, Shailendra?
No, they don't require internet at that point of. If you're not sending the images anywhere, that's fine.
Great. Okay. I think we've come to the end of our hour. All other pending questions, I think CyberSight team will send us, and we hope we'll be able to answer that offline. Before we end, thank you so much for being with us. I can see there was a very large number of participants online, and I know this is now shared onto the CyberSight website, and all of you can view it later. And we are open to receiving questions from you even after this webinar ends. Thank you, CyberSight team. Thank you, Shailendra, and on behalf of the team here, thank you very much. Have a great day from whichever part of the world you are viewing us. Thank you once again.
Thank you. Thank you.